I know a lot of you here are providers. We have physicians. We have all kinds of medical specialists. But really, our most important guests here today are really the patients and family members who live with this condition on a daily basis. But today, we are all learners. We will learn from you. You will learn from us. We'll learn from each other. And so we're very excited about this program you have in front of you today. And so without any further ado, I'm going to actually bring on the real star of the show up here, and that's Dr. Amy Case. So please welcome her. And by the way, she has laryngitis, so she's not normally this quiet.
We'll see how this goes. Just set him here. That's fine. I won't go too far. Huh? All right. Good morning, everybody. Is that going to pick up? Can anybody hear me? How's that, Nathan? You got me? Can anybody hear me back there? All right. Hold on. This is about all I have, so we'll see how it goes. Maybe I can hold this guy. How about that? Is that better? No. I might just have to hold it. All right, here we go. So, sorry, let me go back here. So this is me this morning. I was trying to be very entertaining, Michigan J. Frog, but instead I think you're going to find that I look more like this. Or this girl. So I have a raging case of laryngitis, and I apologize in advance for that. But I'm going to get us started with just some really... All right, I'm going to start. How's that? Is that better? I'm doing the best I can, you guys, because I start to squeak if I get a little louder than this, and it's worse. So I'm going to get us started on just the real basics. We're going to hear from a lot of people today, a lot of different specialties, some guests from within Piedmont and outside of Piedmont. About pulmonary fibrosis. So whenever I don't know about something, I ask the internet. And whenever you come to my clinic, I say, don't ask the internet stuff. So the other day I Googled, what do I do if I have pulmonary fibrosis? And a lot of really terrible things came up. But if you go to Wikipedia, pulmonary fibrosis is defined there as diffuse parenchymal lung disease. Boy, does that sound crazy. A group of lung diseases affecting the interstitial, or the tissues and spaces around the alveoli or air sacs in the lungs. So this is a nice demonstration of that spongy kind of lung tissue. I think I have a pointer here. Yeah, if you can see that. So this would be more like normal lung here. So these are the tiny little air sacs. If you think of your lungs as an upside down tree, and your windpipe being the trunk of that, and all of your airways being branches of that, then the leaves on the ends of that tree are the air sacs where all the oxygen gets into your bloodstream. And in interstitial lung disease or pulmonary fibrosis, I'm sorry, I'm really making a big mess of things here with this voice. The spaces in between there in that spongy little lung tissue are wider because of either scarring or inflammation, or maybe some of both. So this is a nice gross demonstration of, not gross because it's yuck, but gross because that's what we call it in pathology, of a normal-looking, healthy pink lung. I mean, it can't be too healthy. It's not in a person. And then a very pathologic lung with lots of pulmonary fibrosis. Oh, thank you. That's much better. Doesn't help my voice at all, but you guys can see the pretty pictures. And you can imagine how stiff and difficult to breathe it might be if you had a lung that was like that. So how do we as medical professionals evaluate interstitial lung disease or pulmonary fibrosis? Well, if people ask me what is one test you can do or one thing you can do if you're trying to sort out a patient with pulmonary fibrosis, say, look, I just give me a really good history. If you come to my office, I ask you a lot of questions, and some of them seem relevant, some of them don't, and some of them are relevant, and some of them really aren't. So if you, Sir William Osler is the father of modern medicine. He's attributed with this quote. I don't know how real it is, but the internet said he said, listen to the patient. He's telling you the diagnosis. I actually heard that before the internet was like a big thing, so I think it's probably true. What did I do here? There you go. So the clinical history is really important, and hopefully you'll see that as we go on today. Sorry, forgive me. So very different situation that you're setting up when I say that the patient is a 34-year-old female that has systemic sclerosis versus a patient that maybe doesn't have that, but was 15 years in an asbestos mine and retired 10 years ago. Or maybe a patient who has a phoenix in his office. That guy, birds and feathers, we care about those things too. And maybe you'll see a little bit more about why that is later today. So when we're thinking about the framework for evaluation of pulmonary fibrosis, that kind of can walk through some of these steps. And so if there's an identifiable cause, then that's very helpful, and that can get you to differentiation of just in the clinical history or physical exam findings, what might be going on with the patient, what could be causing their lung disease. So if you think about causes, and you want to keep things simple because it can get very complex, I like to think about the the autoimmune diseases, so systemic inflammatory conditions where the immune system is acting against the person's own tissues, exposure-related diseases, and when I say exposures, that's very broadly used, so medications, environmental exposures, things we inhale, and so on. Genetic causes, and then idiopathic disease. And people have certainly heard the term idiopathic, most of you. It doesn't mean that your doctor's an idiot. It just means that we can't always pinpoint the exact cause. We know some risk factors, perhaps, but we don't have a good sense of exactly what has caused the problem in the pathology in the lung. These are some physical exam findings that we look for. So we don't just listen to the lungs. Most people's lungs actually sound pretty similar. They have some we call crackles or rolls. If you have hair that reaches by your ear, you can take it and like rub it like this. Kind of sounds like that. Or like Velcro coming apart. Or maybe even if you listen to a bowl of Rice Krispies, might sound like that too. That's pretty common. Clubbing of the nails is not found in everybody, but that may be a feature of disease. And other systemic signs outside of the lungs could be indicative of an associated condition. So arthritis, skin changes like rash or skin tightening, and muscle weakness. So this is not intended for you, it won't be on the test, but it's to sort of impact you with how many things might be going through your doctor's mind, if, probably not all of these things, this is from a textbook, of the possibilities when you say somebody has pulmonary fibrosis or interstitial lung disease. You're talking really about an umbrella term that could encompass over 200 different types of more specific conditions. So when we ask a lot of questions and think about a lot of things, these are some of the things that we're coming up with. Although the last time I saw thatched roof lung, I just don't even remember. Sheila Green is going to talk to us about lung function tests, but that's something that is pretty consistently used to evaluate patients with pulmonary fibrosis. And most people will have some sort of chest imaging. And really the standard of care here is what's called a high-resolution CT or CAT scan of the chest. And that helps us look at the pattern of lung disease that we're dealing with. We can see different types of changes in the lungs. I'll show you a few. Different areas of the lungs that could be affected, from more around the airways to the periphery of the lung. That's more out to the underneath the chest wall or outside of the chest. More extensive or focused in the bases or upper parts of the lungs, and all of those pieces of information are useful and important. I will say, though, that a high-resolution CAT scan, in lots of cases, can obviate the need for lung biopsy, although it doesn't in every case. What you can see with a CAT scan is essentially what you could see if you had X-ray vision, but not microscopic vision. So it's not going to show you what the cells look like. It does show you what you could see if you sliced a person open and looked at their tissue with your eyeball. And it wasn't too much of a mess to do it that way, I guess. So you can kind of see a demonstration of that here, where this is, so when you're looking at a CAT scan in this kind of projection, you have to imagine that there's a table lying here. Everybody's had a CAT scan's been on that table before, coming out of the screen here, with a person lying with their head that way, their feet this way, and then they get sliced like a loaf of bread, okay? And then we look at all the slices of the loaf of bread and see what they look like, right? So if you're looking at raisin bread or banana bread or whatever, all those different ones. And so here we see that, so this is the heart in the middle, right lung and left lung, and we can see all of this scarring area. We call this honeycombing. Radiologists and pathologists like to name things after stuff that they can identify in the real world. So this the look to somebody like a honeycomb, like a bee would have in their home. So, but you can see how that correlates to where if you could just open that person up, you could see the way that lung looks, okay? But it's not a microscopic view necessarily. And this is a representation of scarring or fibrosis in the lung, okay? And fibrosis, in case I didn't define that, it's just kind of a fancy word for scarring. Oops, wrong button. This is more just some different radiographic patterns that we can see. We're not going to go into too much detail, but you can see this is kind of a more normal area of lung. So on a CAT scan, air is black, and your lungs are supposed to be full of air. They're like sponges full of air, though, and not balloons full of air. So they've got some tissue, blood vessels, and so on associated with them. So they're not totally solid black, but they're kind of black and a little haze. But this is sort of a normal-looking area. So your lungs should look about like this throughout. But here, this is pretty abnormal. This is an airway, a bronchial tube that's wider than it should be. You call that bronchiectasis. And then there's some more of this, maybe some honeycombing here, and then also what we call reticulation or a lacy-looking or maybe almost spiderwebby-looking pattern. Or scarred pictures. This is kind of more of that same types of features here. I got too many pictures. I didn't hide this one. So some people might have heard that they have ground glass in their lungs. Anybody heard that before? So then you thought, oh my God, where did that come from? My goodness. So like radiologists like to name things after what they know. So if you've seen ground glass before, you can see light through it, but you can't necessarily read a newspaper. And that's kind of this look that you see in the lung. It doesn't obliterate the underlying architecture. You can still see the blood vessels, the airways, and such underneath, but it's kind of this hazy appearance to the lung tissue. And that to most of us will mean that there's something wrong in that lung tissue. Something's filling up the little tiny air sacs. And what is that? It's hard to know, because you can't see in the microscope with it. This is not projecting like it should. I think I knew that, but I forgot. This is supposed to be sort of a little nodular pattern with like a starry bunch of dots here. And you can kind of see how that is. It's also got sort of that ground glass look to it. These are a little better projecting nodules. You can almost see like Milky Way here, but these little dots here we will call nodules. they're small, and where those are in relationship to the other structures of the lungs is important when we're talking about what's wrong with a person's lungs. So these are all features that are important, and the high-resolution CT shows us all of this. And these are cystic changes. So these are thin-walled cysts. They don't have thick walls to them, but now it's like holes in the lungs, right? And so this makes us think about maybe a different category of disease than some of the other findings that we had. All right. So depending on the pattern, and we're not going to get too much into the details of why you would think one or the other, we are going to have a demonstration of how we kind of walk through this between a clinical pathology and radiology team. Some people need a lung biopsy, and to look at that tissue under the microscope and see what those cells look like. This is a bronchoscopy. Some people will get a bronchoscopy instead of a surgery biopsy if they need tissue. But a lot of times people with interstitial lung disease will need a bigger piece of tissue than a bronchoscopy will allow them to have. A bronchoscopy is really good for looking at infections, perhaps lung cancer, at certain types of interstitial lung disease, but not all. The biopsy pieces on a bronchoscopy are very small. It's less invasive, so that's a good thing. It's an outpatient procedure for most people. And if it can help, and if the suspicion is one of those things that are diagnosed easily on a bronchoscopy, then people will get those things first, perhaps. This is a surgical lung biopsy. Most people at this point, hopefully, are not getting open biopsies, but what's called a video-assisted thoracoscopic surgery. And so most people have heard of a laparoscopic surgery, where a surgeon may have used small incisions to get out a gallbladder or a appendix or something like that instead of making a big incision. So the same thing can be done in the lung. So small incisions with tools that go in and a camera. The camera projects here on screens, and then the biopsy tissue can be taken out through those small incisions. Shorter recovery time, shorter time in the hospital, so on and so forth. And here at Piedmont and other places, we're also doing these robotically. So so even better in terms of downtime, recovery time. And so this is going to be some demonstrations of what we can see under that microscope. I think I'm going to time. This is a normal lung, okay? So when we talked about the little air sacs, these are them, teeny, thin walls. You can imagine oxygen would have an easy time getting into blood vessels through those, and airway here in the middle. Contrast that with this. All this pink is scar tissue. Maybe a little bit of normal lung here, but you can imagine that a lot less of this normal lung to transfer oxygen into the system, and a lot of scar here. And this is a more inflammatory appearance here. So this blue kind of, or purple kind of picture is inflammatory cells. And then this is a granuloma that's characteristic of sarcoidosis. We see granulomas, it's just a type of inflammatory change. We see those in other types of diseases, but this in particular is sarcoid. Hello. And so then, what do we do with all that information? So patients with interstitial lung disease or pulmonary fibrosis are kind of like a puzzle. And we have to put together the clinical, the radiologic, and the pathologic information to come up with a diagnosis. And really the gold standard is that those different specialists will discuss and go back and forth a little bit about what they're seeing. And do you see this? Oh, well, I got this feature. Do you see any of that? No, I don't. What do you think about these things, to come up with a consensus diagnosis for the patient? So quickly, because not all pulmonary fibrosis is IPF, but lots of people do have IPF. So what is IPF? So IPF is a chronic, idiopathic, usually progressive scarring disease of the lungs. We don't really know exactly where it comes from. The thought is that there are lots of things that can contribute to the pathogenesis of IPF. It's generally limited to the lungs. Typically seen in older adults, more often in men than women, but certainly younger people and women do get IPF. And it's associated with a very specific pattern of lung injury on that high-resolution CT of the chest in a lung biopsy. And these are some famous people. If anybody's ever been here before, I repeated some of my slides, so I'm not going to go through and quiz you about who they are. This slide is just demonstrating the potential courses of a patient with idiopathic pulmonary fibrosis. This could apply, I think, to multiple types of diseases, lung diseases, but particularly in IPF. There's a minority of patients who will present with whatever lung function they have at time of presentation and have a very rapid progression and decline in their lung function and functional status. There is another minority of patients that seems to stay stable or relatively stable for a long period of time when it comes to their lung function and how they're doing clinically. And then the majority of people have a slow but steady progression and decline in their lung function over time. Although every person with pulmonary fibrosis is susceptible to what we call an acute exacerbation or an acute worsening of their respiratory status that can be triggered by infections or other insults to the system, and sometimes they're completely idiopathic as well. And those are unpredictable. So, button. When we think about, well, I already told you we don't really know exactly what causes idiopathic pulmonary fibrosis, but we do know that there are some risk factors to that. And that can then lead to, this slide is nice because it sort of highlights some things, but I will say that certain other parts of this might make you think that somebody had another type of non-idiopathic pulmonary fibrosis. So, but these are certainly things we think about and look at in our clinical history. So what is UIP? Some people come in and they say, I have UIP. Usual interstitial pneumonia is not infectious pneumonia. It doesn't get better with antibiotics. Pneumonia in this case is just used for to mean something's wrong with the lung. And it's not usual, so that's kind of a misnomer, but it is interstitial, so we get 1 out of 3 there. It's a very specific pattern that we can identify on high-resolution CT of the chest and or a surgical lung biopsy. It's a pattern of fibrosing lung disease. It correlates clinically if it's idiopathic and doesn't have a specific cause with idiopathic pulmonary fibrosis. But people can have this pattern from other types of lung injuries. So when I'm teaching our trainees or students or anything like that, I always say, look, not all ILD is IPF. You don't take anything else out of here. Not all ILD is IPF, and not all UIP is IPF. Okay, so keep that. It's very confusing, right? Alphabet soup. That's what I felt like in school. So we do have disease-specific therapy, anti-fibrotic therapy for IPF, and there's some more information in the lobby about these things if you're interested. They're the 2 FDA-approved therapies for idiopathic pulmonary fibrosis is what they're approved for. Esbriet and Ofev, or pirfenidone and nintedanib, do slow disease progression, and I will just leave it at new treatment options are being looked at as we speak, because nobody thinks these are the end of the story. So this is a plug for research and being a participant if you're a candidate to do so. We do clinical trials here at Piedmont. They're done elsewhere in the state, all over the world. Everybody involved in interstitial lung disease research is looking for something to improve the clinical course to stop disease progression and hopefully find a cure one day. So if you're interested in research opportunities, ask your doctor where you can get involved. Look at clinicaltrials.gov, ask the folks here, because we perhaps could help you get hooked up there. So what can we do, right? Because I do hear people come to my office, they say, I came here because my doctor told me there's nothing really that he or she could do for me, so here I am. So we do have some disease-specific therapies depending on the underlying etiology of the lung disease. So if it's IPF, we have antifibrotic therapies. If it's autoimmune disease, for example, we use medications that suppress the immune system. Clinical trials are really important for diseases like this, and the more research we can do, the more options we'll have for people in the future, and the closer we get to curing these diseases. Transplant evaluation, we'll hear more about this afternoon. For the right candidates, transplant organs obviously are not growing on trees in the backyard, and it's not for everybody. But that's something that should be thought about at least. Oxygen therapy, and in at least one of our small group sessions, we'll have a little bit of discussion about oxygen when it's appropriate. Not everybody with pulmonary fibrosis needs oxygen right away, but it is an important therapy. Pulmonary rehabilitation, we're definitely going to talk about that in our supportive care and self-management small groups. So if you're interested in hearing more about that, we also have programs within Piedmont. We have 4 pulmonary rehab programs here, monitored exercise programs for people with lung disease, reflex evaluation and treatment if people have it, vaccinations, a good preventive care, management of, and also management of comorbidity. So comorbidities are other medical problems that people have. So if you've got heart disease or diabetes or things like that, don't let those go just because you got pulmonary fibrosis. You got to take care of the rest of you and make sure the rest of your machine is being taken care of. Symptom management, so in disease where we can't reverse or necessarily cure, we have to think about how do we help with the symptoms and take care of people's needs that way. And then we have to think about people's mental health, and then sometimes palliative and end-of-life care as well. We'll talk more about those in different settings today too. So we have a packed schedule today, and I would like to introduce Michelle Peters. She's one of our Pulmonary Fibrosis Foundation ambassadors. The ambassador program is a signature program for the PFF. It consists primarily, I think, of caregivers and patients with pulmonary fibrosis that go around the country and share their stories and meet people. And so we're very fortunate to have Michelle with us today. So everybody welcome her, please.